Okay, so today we're going to tackle a topic that's, well, it can be sensitive, but it's a really crucial part of clinical psychiatry. We're talking about sexual disorders. And to help us get a clear clinical look, we're going to be using a short textbook of psychiatry by Neeraj Ahuja as our guide. It's all about approaching this with precision and, empathy. So let's just start with the big question that's going to frame everything we talk about today. What's the actual clinical difference between a sexual preference and what's called a sexual disorder? And I really want to stress that word clinical, because as we're about to see, the answer has absolutely nothing to do with morals or what society thinks. It's all about a specific diagnostic framework. All right, so here's how we're going to break it all down. First, we'll get a handle on what a sexual disorder even means from a clinical standpoint. Then we'll dive into gender identity and maturation, disorders of sexual preference, and then we'll look at sexual dysfunctions. And we'll wrap it all up with how these things are actually diagnosed and treated. Okay, so first things first. Before we jump into any specific conditions, we've got to build our foundation, right? So what does a clinical textbook actually mean when it uses that word disorder? This right here, this definition is basically our anchor for this entire conversation. And you'll notice it's not so much about the behavior itself, but about the impact of that behavior. The key phrases to hang on to are significant distress, disability, or loss of freedom. That's what really matters here. So let's break that down a little more. What's super important to see here is that a disorder, clinically speaking, is not just behavior that society finds weird or deviant. It's not just about a person being in conflict with society. The real turning point is whether there's internal distress or some kind of actual dysfunction, psychological or even biological, that's getting in the way of a person's life. And that distinction, it's everything. It's what separates a clinical condition from just a preference or an identity. All right, so with that foundation in place, let's move into our first big category and see how this definition applies in the real world. We're going to start with conditions that are all about a person's internal sense of their own gender. Okay, so the textbook defines transsexualism like this. Now, the phrases to really pay attention to are persistent and significant discomfort. We're not talking about a feeling that comes and goes. It's a deep, core part of someone's experience. It's also worth pointing out, this textbook uses the term transsexualism, but the language we use around gender identity has definitely evolved, so you're likely to hear different terms used today. And a comparison like this really shows you why that precise clinical language is so important. By being able to distinguish between, say, transsexualism and dual-role transvestism, a clinician can get a much clearer picture of what a person is experiencing. And that means they can provide the right kind of support. I mean, look at the motivations. They're totally different. One is about identity, about wanting a permanent change. The other is about a temporary experience, and it doesn't involve sexual excitement. All right, let's shift gears to our next category. We're moving from gender identity to the focus of sexual arousal. These disorders are known clinically as paraphilias, and the key thing to understand is that they're not about who a person is, but about what their sexual arousal is focused on. So here's the big definition from the textbook, and hey, look familiar? There are those words again, persistently and significantly. This is so important. We're not talking about a random fantasy or just being curious about something once. For this to rise to the level of a clinical diagnosis, that pattern of arousal has to be intense, it has to be recurring, and it has to be pretty central to a person's sex life. Fetishism is a really classic example of this. The clinical definition says that sexual arousal is focused either completely or mostly on a non-living object. And the text makes a really important distinction here. This isn't the same as just using an object to, say, enhance stimulation. In this case, the object itself is the main event, the primary source of the arousal. Another one the textbook outlines is exhibitionism. And for a diagnosis, you're looking for a few key things. The act is persistent or recurrent. The whole point is sexual arousal. And this is critical. It's directed at a stranger who is unsuspecting. In other words, a non-consenting person. And in a similar vein, you have voyeurism. Clinically, this is defined as a persistent tendency to get aroused by watching unsuspecting people, people who are naked, getting undressed, or having sex. And just like with exhibitionism, that lack of consent is a fundamental part of the clinical definition. Okay, on to our third and final category, and this one's pretty different from the last two.
Sexual dysfunctions. These aren't about your identity or what you're attracted to. Instead, they're all about a disturbance in the actual process of sexual response itself.
So, to really get what a dysfunction is, it helps to first look at how the process is supposed to work. The textbook breaks down the sexual response cycle into 4 stages. You've got the appetitive phase, which is desire, then the excitement phase, or arousal, then the orgasmic phase, and finally, resolution. A dysfunction can pop up at any one of these points. Maybe there's a lack of desire at the start, or maybe there's a problem with arousal or reaching orgasm later in the cycle. And the causes for these dysfunctions can be all over the map. They can be psychological, they can be biological. Let's take male erectile dysfunction as an example. The book points to a bunch of psychological factors, things like fear of failure, performance anxiety, problems between partners, or even things like anxiety or mood disorders. It really just goes to show you that powerful mind-body connection. What's going on in our heads can have a very real, very direct physical impact. But, and this is a big but, it's not always psychological. And this is exactly why getting a full clinical picture is so important. Just look at this table from the book. You can see how common things, we're talking blood pressure meds, SSRI antidepressants, even alcohol, can directly mess with different parts of that sexual response cycle. And understanding that is huge, because it means the solution might not be psychological at all. Okay, so we've got the definitions and the categories down. The next logical question is, what do you do about it? How do clinicians actually approach these things? Let's get into our final section and talk about diagnosis and treatment. And this right here is probably the most important principle in the whole process. Step 1, always, is to rule out any physical causes. Before you even start thinking about psychology, you have to do a thorough physical exam and take a detailed history. Why? Because you've got to make sure you're not missing something physical and treatable, like a hormone issue or just a side effect from a medication. Okay, so once you've ruled out physical causes, a whole bunch of therapeutic doors open up. The textbook mentions several different routes you can take. You could treat an underlying issue, like an anxiety disorder, or you could use specific psychotherapies. For example, psychoanalysis tries to get at deeper unconscious conflicts. On the other hand, you've got something like behavior therapy, which is much more practical, using techniques like relaxation. Then there's dual sex therapy, the famous Masters and Johnson's technique, which treats the couple together. But no matter which path you take, the goal is always the same: reduce that distress and improve function. And let's just end on a final thought here. The textbook we've been leaning on was published back in 2011. And psychiatry, well, like any science, it's always evolving. So as we learn more about the human mind and as our social norms continue to shift, you have to wonder, how might these clinical definitions change? What will this all look like in another 10 or 20 years? It's definitely something to think about. Thanks so much for joining me.